راح نبلش اليوم هلا بسيشن 2 من الكونفرنس اللي هي Beyond the Basics Mastering Advanced ACS Care. With pleasure, I would like to introduce Dr. Mohanad Ababne. Dr. Mohanad Ababne is assistant professor at Jordan University of Science and Technology. He will give us a lecture about inpatient care for ACS from emergency to stabilization. تفضل دكتور.
Thank you, Dr.
يا دكتور رائد نقعد محلنا إذا
for
سمحتوا.
this.
جميعا دكتور جميعا نقعد محلنا إذا سمحتوا. شكرا.
Thank you, Tariq, for the nice introduction, and thank you for this valuable meeting where I think we are going to get some great values for the healthcare system in Jordan out of this. My part in my presentation is about the inpatient care of acute coronary syndrome, which Dr. Qais recommended this title, from emergency to stabilization. I'll say from emergency to discharge, because it's an ongoing, flowing process. Why do we need a special recommendation for the care of acute coronary syndrome patients in Jordan? We've spoken a lot about this, but I think what we have really a difference, what Dr. Faraz mentioned earlier, we have population risk. We have different population risk in Jordan and other countries. We have a high rate of smoking. We have a high rate of diabetes and obesity. The age of MI we have very early presentations of MI in our population. Otherwise, we have a huge disparity between rural and urbanized areas where we have different levels of care, what the patients are received. When we speak about acute coronary syndrome, we will find in the guidelines, mostly the European, they are classifying the acute coronary syndrome patients in two classes: non-ST acute coronary syndrome, including the unstable angina and non-STEMI, and the ST elevation MI. The difference in management after classifying the patients in one of the two categories of the ACS is depending on the subtype, non-ST or ST elevation MI, the specific patient risk profile, what's his, whatever we call it, GRACE score, TIMI score, patient's individual risk, and if PCI is available or not in the institution where we are meeting this patient. General principles for all acute coronary syndrome patients. From emergency department, from starting the triage of these patients have to be monitored. Continuous cardiac monitoring during transfer, emergency department transfer, and then the hospital course. Even on the way from CCU to the cath lab, these patients have to be continuously monitored. We have early to use a scoring system, as we previously seen with high sensitive troponin assays. We can rule out patients and send them home. Therefore, early stratification of the risk of the individual patients. Patients with low risk, with negative enzymes, may have another pathway as those who have initially high risk or very high risk stratification or valued as very high risk patients. Transfer for PCI is to be planned immediately after making the diagnosis of ACS. I think that's because we know it's a cascade that needs time. We have to start it, even if we have non-ST elevation MI patients. We have to make here the step, and not to forget about secondary prevention in these patients before discharge. We'll come into this at the end of the slides. Why do we need early management? As Dr. Mustafa mentioned earlier, time is muscle, and Dr. Raed, time is muscle. Mostly, it's not just muscle, it's also money. It's economical value. These patients who are having MI, the delayed infarct resolving means loss of muscle, that's loss of function of myocardium. These are landing as heart failure patients who are going to make additional costs on the healthcare system. Not timely treatment produces also recurrent interventions or more need for further interventions. We are speaking about patient health, morbidity, mortality, and costs for the individual patients and healthcare system. Why do we need risk stratification? Why does it matter? Mostly used or recommended in the guidelines, we find the GRACE score, TIMI score. The guidelines did not put us to use one specific risk stratification system, but they encourage us to use at least one. to get it standardized for every GP, every resident in the emergency department, how to deal with these patients. In the emergency department, it's not cardiologist sitting there, not to decide that's a hot case or not. We need some objective values. And patients with high risk score, such as the GRACE score with a score what is considered high risk, more than 140, are going to deal with an invasive strategy, even if these patients are unstable angina patients. What we are mostly using is the TIMI score because it's easier. It's just eyeballing over the patient, cooking his age, his risk factors, if he has previously cardiovascular disease or others. And GRACE score, here's a link to the GRACE score. We can find this in the MedCalc and very websites. There is a specific app. TIMI score and HEART score, just to mention a few of them. In the acute coronary syndrome, the following are evidence-based recommendations for the in-hospital management. These recommendations are based now on the actual guidelines from the European Society of Cardiology and the ACC. We're speaking about 2023 and 2021 guidelines. We are taking these three scenarios. The patient presenting with unstable angina. As mentioned, we make our risk stratification like the GRACE score. Initial management will be, as previously always also mentioned, with antiplatelet therapy, anticoagulant. These patients have to get heparin, and if needed, of no contraindication, nitroglycerin and beta blocker. The risk assessment and decision for transfer of patients with unstable angina or for rule-out pathway. The high-risk patients, these are patients with ongoing chest pain or in shock with high GRACE score more than 140. They are to be planned for PCI within 72 hours. If very high-risk patients, also earlier, within 12 hours. In low-risk patients, they are patients with a GRACE score less than 109. These patients with the diagnosis unstable angina, that means we are going to wait for the high-sensitive troponin values. If they keep or still negative, they are still assigned as unstable angina patient with very low risk, GRACE, as example, less than 109. These patients can be dealt with as outpatients. In some cases, we can perform coronary CT or treadmill testing for them. The scenario of non-ST elevation MI, this is, as mentioned in the European guidelines, they make the difference non-ST acute coronary syndrome. This is the patients with positive troponin enzymes. If the zero value or after 1 hour, they are diagnosed with non-STEMI. Also here, the initial treatment with aspirin, anticoagulation, beta blocker, and nitroglycerin. We have here to remember that the actual guidelines now does not recommend dual antiplatelet in these patients anymore. It's considered as class 3 recommendation that's harm to start these patients with dual antiplatelet by making the diagnosis. Even depending on their risk stratification, we are going with early invasive strategy or delayed invasive strategy in these patients. Patients with very high risk, GRACE score with more than 120, have to receive their cath within 12 hours to up to 24 hours. Unstable patients needs, because of their instability, the immediate revascularization. Delayed transfer for low-risk patients. As we said in the unstable angina fraction, now it's the non-STEMI patients with low risk. We have positive enzymes with low GRACE score, less than 109, but his enzymes are positive. That's now MI patients. These patients need also cath, but this can be delayed up to 72 hours. And not to forget with the medical treatment that they have to be on high dose statins for secondary prevention. Here's a short case of 64-year-old male patient with a GRACE score of 145 coming to the emergency department with typical chest pain for 3 hours. His onset of pain and troponin values are positive. These patients' management is now, frankly, obvious. I think it's high-risk patients with positive cardiac enzymes. That's non-STEMI diagnosis, as this patient is receiving his initial management, aspirin, anticoagulations, and additional drugs, and is transfer for PCI within 24 hours is to be arranged if this is a non-PCI hospital where we are. That's why we need the risk stratification for decision of timely or when to escalate the treatment scenario. Patients with ST elevation MI, in this case, we don't need to wait for the cardiac enzymes. We do them for follow-up of the patients to estimate the infarct size and for follow-up. But when it's PCI and the hospital has no PCI available, what's very common in the country when we are going outside of Amman, these patients have to receive fibrinolysis. And here comes the challenge, what we mentioned previously. From first medical contact to ECG within 10 minutes. In these 10 minutes, we have to perform the ECG, to see the ECG by experienced doctor, to decide for fibrinolysis, and to give the fibrinolytic therapy. I don't know how long these 10 minutes can last, but the recommendation will encourage us to think about time. Time. If I can transfer the patient to a cath lab where he gets his revascularization within 120 minutes, that's the first line option. Otherwise, within the 10 minutes rule, fibrinolytic therapy. Even transfer of patients is not as simple as it is because it's a huge logistic challenge in some places in Jordan, and it takes time, it needs organization. And we don't have this level 1 or level ambulances everywhere in the country. And we see very ST elevation MI patients coming to the emergency department with recurrent ST elevation, which happens on the way. And there is nothing to monitor this or to get the information. Patients who received thrombolytic, as in many cases shown by Dr. Mustafa, they have to be the transfer for these patients for the PCI-capable hospital is to be immediately planned. Routine PCI is considered within 24 hours to be done, and risk PCI if the thrombolytic is failed. And I think here's the question, when we consider thrombolytic as failed, and what is real successful thrombolytic? I think that's left for the discussion later because we differ between clinical success of thrombolytic and angiographic success of the thrombolytic. That's not the same. And not to forget that streptokinase is not approved for thrombolytic therapy in MI. Medical therapy of ST elevation MI patients. In this case, we may give the dual antiplatelet to the emergency department. That's not a must, but it's not a failure to do so. Anticoagulation of these patients, and that's the point where we miss sometimes. We have the problem with these patients transferred from peripheral hospital where they give heparin, which lasts of action about 2 to 3 hours. Then patient transfer after successful thrombolytic therapy needs more time than these 3 hours. And that's the cause why we see in up to 10% of cases after a primary successful thrombolytic therapy that they come to the emergency department in the secondary hospital or they're referred to with a new onset of ST elevation. Beta blocker and statin, as mentioned, for every patient diagnosed with acute coronary syndrome, and to monitor of these patients initially for arrhythmias and monitoring for them for complication, including cardiogenic shock or arrhythmias. Monitoring and complication is a part that's coming later, but as mentioned, continuous monitoring, repeat of cardiac enzymes and ECGs, not just to make the diagnosis of cardiac enzymes, as Dr. Hadi said, we need just high sensitive troponin and we can make the diagnosis. But if we need to follow up our patients, here comes the role of using CK-MB and CK and other cardiac enzymes are possible. That's of clinical relevance. Echocardiography is to be performed in these patients as early as possible, and if suspicion of heart failure or any murmur, new onset of murmur, then we have to repeat the echocardiography. When PCI is not an option, we have sometimes patients that's not planned for PCI because of their one or the other medical condition. If it's not an option, we will start dual antiplatelet therapy in these patients. High-intensive statin, beta blockers, oxygen, as mentioned previously. Once stabilized or one PCI is capable, we will schedule for PCI in these patients. Educate patient and his family on lifestyle and warning sign of anginal pain, what to do. I have this averaged from our hospital and from Germany, because the numbers is mainly from Germany, but we have the similar numbers in STEMI patients in our hospital and non-STEMI patients. When you look at the primary PCI patients and the patients receiving thrombolytic, we have always longer hospital stay in patients who was not going through PCI. As PCI is reducing the hospital stay in 1 to 2 days in average for every patient. In this slide, I would just go through the medication for ACS patients by discharge. Will you mention this in your presentation, Qais? Or? Then we'll let it for Dr. Qais. Not to forget in patients with heart failure, just to start to mention here, that we start with the heart failure treatment by making the diagnosis, the 4 pillars of heart failure, to start them even if it's not clear. Patients on oral anticoagulation, you will mention it, or? I think we will make here specific recommendation for these patients regarding on their bleeding risk, and how long do we have to to keep the dual antiplatelet therapy. Patients with very high bleeding risk, we can reduce the dual antiplatelet therapy for less than 1 week if necessary. We just keep clopidogrel and preferred DOAX or NOAX, and never combine ticagrelor and warfarin. It was harmful. In patients with moderate, intermediate risk or low risk for bleeding, we may consider discontinuation of DAPT after 1 month and keep the patients on clopidogrel and NOAX for 1 year. If the patients in this time, in the 1 year, have no recurrence, no angina, no signs of acute coronary syndrome, of unstable coronary artery disease, then we may consider reducing the treatment for the anticoagulation only. Before hospital discharge, medications to be optimized, education and adherence counseling for the patients, and we have to schedule early outpatient follow-up. Many patients are loss of contact because they think, I'm good now, I'm not coming back. They think it's not appendectomy where you visit the surgeon once in life. Cardiac artery disease is a chronic disease. You are treated now for this acute exacerbation, but it may happen again. Conclusions, all patients diagnosed with acute coronary syndrome with high-risk features, according to scoring, to gut feeling, however, are aimed to undergo coronary angiography as soon as possible. Central organized transfer to a hospital with PCI capabilities can facilitate this and save time. It's what the Ministry of Health started since 1 year, and it's a successful project. When PCI is unavailable, the timely administration of fibrinolysis and careful risk stratification and critical will improve the outcome. That's the 10-minute rule. And patients should be transferred to PCI-capable center as soon as possible for definitive care, ensuring adherence to evidence-based protocol for optimal management. Thank you very much. I hope it was not too much.
Thank you, Dr. Mohannad. Shall we leave the questions until the end?
Now
Yes,
or later?
Later, I guess. Our next speaker was supposed to be Dr. Hani, but Dr. Hani won't be available. So we'll move to the third talk by Dr. Qais Bilbaisi. We all know Dr. Qais. He's an associate professor at the University of Jordan. He will give us a talk about post-ACS care, strategies for optimal recovery and secondary prevention. Thank you.
Thank you. Thank you for your kind introduction. Also, just as a matter of kind of housekeeping, all these lectures are going to be recorded and will be posted on our JCS website. It's actually currently a live transmission. And if any questions come by, please feel free to send them to us. I will be happy to answer more of your questions. All right, so moving to the meat of our talk today, the post-ACS care. And as we said, prevention is the key. So we want to take care of our patients. We've done a good job, hopefully, until now, and now they're going home, so we want to keep them home in a healthy state. So what can we do? Of course, I have to disclose that this lecture is sponsored by Novartis, and we appreciate their help actually in sponsoring the whole conference. In addition to Roche, this partnership helps to kind of move medicine forward and increase the education. So objectives, a couple of questions we want to answer. Why post-ACS care is important? Second one is, what are the phases of post-acute coronary syndrome care? There's the transition of care, there's the early hospitalization, post-hospitalization, and then long-term care. So let's talk about why is it important. It's important because we've been spending the whole morning talking about it. It's the leading cause of death, not just in Jordan, worldwide. And out of the cardiovascular diseases, which is kind of an amalgam of diseases, ischemic heart disease is the most important, kind of the leading one out of them. And 80% actually of fatalities in Jordan are due to coronary artery disease. So it is a big problem. So we have to take care of it. And this is the key point why post-ACS is important. Afterwards, when the patients are discharged, they're 6 times more likely to have a recurrent MI, 9 times more likely to have a stroke. So they're not out of the woods. And if we don't take care of them well, they're still going to have problems. And as you can see, once the 1-year rate of cardiovascular death after an ACS comes close to 10 to 15%. That's a big number. All right, so how can we make this less of a problem? Usually, we concentrate on things that we can modify. One of the biggest things that we can modify is cholesterol. And we'll come to that, especially LDL. The lower the LDL, the better. So, and this is a chart that speaks what we're talking about. So if you lower the LDL, the more the LDL, you can easily see that mortality goes down. But there's another dimension on this chart, which is how early you lower the LDL. The earlier, the more benefit. So there are 2 things that we're looking at, lower and earlier. All right. And if we do lower it, we do make a difference. So it's not like, he's shot in the foot and that's it. No, we can actually make a difference. All right, so what are the phases of post-ACS care? There are 3 phases that we've mentioned earlier: transition of care, early post-discharge, and long-term care. So transition of care is basically discharge planning. Now, it seems boring. We're talking about discharge. This is the intern's job. It's not really my job. Unfortunately, it's important because if we don't discharge the patient properly, he's going to have problems and he's going to come back with an ACS. Second thing is the first 4 to 6 weeks, there are a few things that we need to look at. We need to open our eyes upon, which is including, like cardiac rehab, the concept of cardiac rehab, and ultimately secondary prevention, which is the long-term care. So what is the checklist? What are the things that I need to look at when I'm discharging my patient? First of all, he has to have a clear diagnosis. You've had a STEMI, you've had a non-STEMI. And what are his risk factors? No patient should be discharged after an ACS without knowing his lipid profile, his HbA1c, is he hypertensive or not. You need to know his risk factors because those are the things that are going to be managed to prevent him from coming back. Okay? So he has to have clear diagnosis and risk factors. He has to have a good revascularization and discharge summary. In a lot of cases, they get treated in a centralized center, and then they go to the periphery. No one knows what they got. Did they get a stent? Did they not? Did they just were treated with medicines? So again, a proper discharge summary is very important for continuation of care. Then guideline-directed medical therapy, which we're going to spend a few minutes more in a few minutes. Then I always tell my students this: medication reconciliations, medications. One of the most common errors and causes of unfortunately death is wrong medications. So we have to sit with them and make sure that they know what medicines they're supposed to take. Schedule follow-up appointments and phase 1 cardiac rehab, which is basically education. Now, here comes what we were talking about, Dr. Muhannad, the guideline-directed medical therapy. You should be on aspirin, you should be on dual antiplatelet, as you said very eloquently, and you've stated all the needed medications, beta blockers, and statins. They need to be on these 4 pillars. But also, we need to control the risk factors. So if he's on a statin, but he's not controlled, maybe we should give him more medicine. And the comorbidities, like heart failure. Okay, so we have to be on the 4 pillars. We need to make sure all these problems have been taken care of. Now, coming to the guideline medical therapy, if you look at any guideline, whether it's the European or the American, you can see they're going for lower LDL numbers. And we're looking at target and goal. Basically, the target is a set number, where goal is an amount of reduction, and you have to achieve both. Now, the most recent guidelines by the American College of Cardiology actually did tackle this particular issue, which is the post-discharge care and risk factor modification. And they particularly concentrated on LDL. And of note is this. So we all agree that if you're not on statin or you need to be on a high dose statin. That is clear. Now this is interesting. If you're intolerant or you cannot take a statin, then you should, from the beginning, start the non-statin LDL lowering medications, which we will talk about in a minute. So, and here comes another point, which is if you're not at goal, and we're talking about 70, where you need to add more to get lower than 55, and if you're less than 55, you're at goal, and that's where you need to be. Now, a big concern, which is all over rampant over the social media, is statins and lowering LDL too much is bad for your health. It's a lot of side effects. It's bad for your brain. You're going to go demented quickly. There's no clear evidence for that problem. As a matter of fact, vascular dementia is probably more of a cause for dementia than actual statins. And this has been proven over so many years at so many different levels, even the lower statin levels. All right. So let's move to the second phase, which is early post-hospitalization care. Here, we're talking about we need to see the patient within 7 to 14 days. We have to follow up his labs, especially the LDL. And we have to, again, sit with him and make sure his medications are correct. We have to counsel him on the importance of medication compliance and go through cardiac rehab. In the follow-up appointment, we should focus on, is he getting better or not? Address any concerns because there's a social, psychological component, and adjust treatment as needed. This is important because some patient might be intolerant to medication or not at goal, and we forget that. So if he's intolerant, we need to be there for him to help fix that problem. Again, it's a class 1 indication to follow up lipid profile after an acute coronary syndrome. Phase 2 cardiac rehab. I want to spend a minute there because it's important. It's not just an exercise program. It's about lifestyle modification, education, and smoking cessation. So this is another big problem in Jordan. Smoking is rampant. His Excellency mentioned it this morning, and that we need to make sure that it's been taken care of. That's part of our ACS post-care discharge, smoking cessation. Psychosocial support, a lot of them have depression, so you need to take care of that also. Again, medication reconciliation and early recognition of complications. Now, long-term care. And this one is the same as phase 2 with different emphasis. So now we need to recognize recurrence of disease. You still have to put a lot of emphasis on risk factor management. And then comes the other good stuff, including stress management, psychosocial support, and education. Now, let's talk about risk factor management. As we said, controlling LDL does make a difference. And if we don't, but the problem is only 33% actually reach goal of all patients, and 18% of coronary artery disease patients reach their LDL goal. So you can see, although we're trying, but we're not doing as good of a job that we should. And this is across different regimens, whether high intensity, low intensity, or other treatments. All right, so there's another thing. There's a lot of high rate of statin discontinuation. This is a problem for 2 reasons. Either patients get side effects, or more importantly, I think, and that's more a bigger problem, they think they're cured and they no longer need statin. So here comes 2 things. First of all, we need to continuously educate and teach them that, no, it's needed. It's something genetic. You cannot get rid of it. And also address any side effects from those medications. So let's say you have a patient who's already on statin and he's not at goal, or he started to have intolerance to statin. What other options do we have, those non-statin lipid-lowering medications? So, as I said, this lecture is sponsored by Novartis, and inclisiran, almost done. Inclisiran is the medication to go to. It is given in 2 injections, usually a year, but the first injection is 3 months only. It has been shown to be effective throughout, both Orion 9, 10, and 11, and there's a considerable reduction of around 50 to 60%. It has a sustainable effort, less than 70 across different years, and this is a good study which is Victorian initiate, and it showed early intervention, early switch to inclisiran actually led to much more reduction of LDL, and at the same time, if they needed that little bit of a statin, they tolerated it, and they were kept on statin more than the other arm, which used the higher dose of statin. Side effects was very favorable, and throughout different years, both in multiple trials, all the way from Orion 9 to Orion 11. This one I like is because it shows the efficacy across different years, across almost 3 years, and still continues to be safe and efficacious. And Orion 8 showed results up to 6.8 years. So our concern that inclisiran might not have as much history should be kind of appeased a little bit more with these data. All right, so in conclusion, number one, we should pay good attention to post-ACS care. Transition of care is where we start. We should have good discharge, good medication reconciliation. We should look into phase 2 cardiac rehab with all the good stuff about it, and ultimately long-term risk factor control and risk factor management, and getting to the goal and using all our tools that we have to get to that goal and number. Thank you so much. Appreciate it.
Thank you. Dr. Mohammed would like to come to the podium, please. Any questions? In the latest guidelines, did they make a do they actually make a difference in or change that we have to choose ticagrelor or prasugrel over clopidogrel in ACS? Because in the previous guidelines, it used to be any of them. Did they make that change, or any one of you?
The European guidelines make clear statement that ticagrelor is to be preferred.
Or
Just if-
prasugrel?
Or prasugrel. Just if not available, you may use clopidogrel.
And did
Same for the
latest,
American.
They
Same for
changed
the American.
it?
Yes.
And how long would you keep patients if they don't have high-risk bleeding for dual antiplatelet? How long would you keep them after an ACS?
You mean with anticoagulation?
No, just dual
In general,
antiplatelets.
it's recommended for 1 year.
1 year, yes.
Okay,
That's the
if
same
the patient
recommendation.
has high risk of bleeding, ulcer or anything, what would you do? If the patient, he told you, 2 months ago I had a bleeding ulcer, would you do any changes?
As an addition, we have to, of course, this adjuvantive treatment with the PPIs.
Okay.
To be treated with. And that's the case where we may consider using clopidogrel instead of ticagrelor because it's
Only
slower
downgrade.
Also, yes.
downgrade
Downgrade.
treatment
I
after.
think there was a change that they said
Yes,
after
correct.
1 month you can stop aspirin. You just put them on ticagrelor
That is correct.
monotherapy.
That is correct. After 1 month, you could stop it. And the other thing also, after 6 months, if you've used a advanced second generation stent, you could also
Yes.
stop even dual and go back to all aspirin.
And after 1 year, if you were to have a choice, if the patient was on Plavix and aspirin, I mean, some of the new studies are saying, I mean, if you have to, you will stop one of them, it's preferable to really keep the patient on Plavix, because that did have more benefit if the patient financially can afford it and he has no complication. Just want to put a couple of points before the questions. The door to needle time is 30 minutes. So when the patient comes, you hit him with an ECG within 10 minutes, you have another 20 minutes to deliver the fibrinolytic. So that's the door to needle time. Now we have a lot of talk about door to balloon. We'll probably, hopefully somebody will talk about the timing. And there is also the door to the onset of chest pain. يعني المريض جايني بعد 3 أيام وهو موجوع. That also has its own calculation. And I just want to stress what Dr. Qais said about the importance, we don't have it in Jordan, the importance of rehab post cardiac surgery or MI. It has a huge psychological effect. Maybe 50% of the patient misery is because of, he thinks it's the end game for him. But we have seen when those patients are in a good rehab center, they really teach them how to cope with stress. He sees other patients who were in a worse situation than him, and that really boosts his morale. So it's very important to hopefully establish cardiac rehab centers, especially in these areas where they are definitely needed.
As a matter of fact, there are certain studies that showed cardiac rehab improves MACE of around 30%. That is as good as beta blockers.
Dr. Rai, then Dr. Hanna. تفضل Dr. Rai.
So I have two questions. First, a question to Qais. I think we are in a community where men and women feel shy discussing their sex life. I'm sorry. So the first question to Qais. We live in a community where sex life, it's kind of like being shy away from discussing it with the doctor. So I think this should be part of the discharge rehab 1 and rehab 2. It's very important for them to feel that they are back to normal again.
100%.
So that's number one. And the question to Muhannad is Brilinta and Prasugrel in the emergency department for ST elevation MI, are they still being recommended before going to the cath lab or not? Thank you.
It's a class 2 recommendation. You may do it. I think that's the thing that you have to be discussed internally. Prasugrel is also not to be given before knowing the anatomy, as Prasugrel had no role in the emergency department at all. Ticagrelor, that's a hospital internal decision. We prefer to give it on the cath table because it doesn't make any difference. Triton, after knowing the anatomy, and this patient's not going for emergent surgery. That was evident in Triton TIMI 38 study that doesn't make a difference if you preload them or give it them after knowing the anatomy, with the benefit that in this case you reduce the cases or the risk of bleeding.
Dr. Hanna.
It's the same point to Dr. Muhannad and the chairpersons. It's regarding the use of the DAPT program in non-STEMI. In STEMI, in our institution, we use it standardized because patient comes down as emergency, and we never sent a STEMI to OR. We never did. So the talk is about non-STEMI. I mean, the guidelines are kind of clear, and I'm sure they based this on trials that you shouldn't be giving the DAPT in the emergency room or ahead of taking the patient to the cath lab. I like your comments in this regard, because to me it's a bit confusing, because how often do you send your non-STEMI patients to CABG again? I mean, the likelihood of advantage is way over the disadvantage, but apparently the trials showed bleeding risk to be high. In practice, it's like schizophrenia. I do it. I'll be honest
We
with
all
you.
do it. I do it.
Exactly, but you are class 3, so you are either harmful or no benefit.
It is not just the risk of bleeding in case of urgent CABG. It's the general risk of bleeding we are discussing. That was mentioned on the guidelines building their recommendation among the ISAR REACT study, where they compared ticagrelor and prasugrel. And in this case, there is no benefit of giving ticagrelor in the patients in the setting of non-STEMI previously to knowing the anatomy. But in this group, there was a higher rate of bleedings, of major bleeding also.
Contraindicated.
Therefore,
No,
the recommendation is coming.
You see my point, Muhannad?
Because of
I
this.
agree with you, Habibi. I agree with you. But see my point, the patient will get it at the end of the day. I mean, you are saving a day or two prior to, correct? But the patient, you're going to put a stent, he's going to be on them like 24 hours after. So long-term wise, he's on it. So, holding it for the chance of CABG is
Which is 5%.
is
Any
a
other
very
bleeding
rare possibility.
Or any
See
other
my point?
bleeding. It's not just the bleeding related to CABG.
Dr. Hadi.
Dr.
تفضل.
Can I make a comment? I think it's a great point which you made, Hannah. But the whole issue is not about cabbage bleeding.
Yes.
That's not what we're talking about. When
And
you
there's more.
upload upstream, you get more bleeding. We're not talking about the cabbage bleeding. We're talking about the site of the cath bleeding. Non-cardiac bleeding like GI bleed, intracranial bleed. Unfortunately, the cumulative data shows that there is an increase of bleeding when you give upstream loading. And that's why the guidelines felt shy and said, well, do it downstream after you know the anatomy. So it's not all about cabbage. I just wanted to point this out.
Dr. Hadi, Dr. Hanna, example. Let's suppose it's at 7 in the morning, a patient came with non-ST elevation MI. Said, okay, perfect, admit him, I'll be there in around 2 hours. would you, two scenarios, would you give him ticagrelor or any, if you're going to do it in the next 2 to 3 hours? That's the first question. And the second question, let's suppose he's admitted 6 in the evening, and you're going to do the procedure in the morning. Would you give at that time?
The
These
answer,
two
the
scenarios.
answer to your question, Tahir, it's all in the guidelines. I
It's
always say
clear.
it's all in the guidelines. If you have the time to read the guidelines, you will find the answer immediately. So if you are going to do an ST elevation mechanical infarction, send them to the cath lab. Early on means within the first 12 hours or so.
Yes.
Then you don't have to upload them. If you are going beyond 24 hours, you can.
You can do it.
You can do it. What's happening with the confusion about these things, I think it just, if my colleagues allow me to make this statement, we cannot make guidelines out of our preferential personal attitude. It doesn't work. If everybody in the audience, in the 180 plus cardiologists registered at the Jordan Cardiac Society, will say, well, this is what I like, this is what I'm used to. I mean, I tell you something, this is not going to be a good medical practice. Guidelines are not made to be Bibles or Quran, كل واحد فينا, because there is an exclusion for them. But it definitely puts almost 9 out of 10 of patients we see on day-to-day basis. You can treat them guideline type of therapy. So this is the
Just
way
to
I see it.
highlight this, what Dr. Hadi says, if you are going to step up with invasive strategy in timely manner, then you are not supposed to preload the patients.
Yeah, there's no benefit.
If it's delayed, it's Thursday and we're going to wait
Sure.
in this unstable anginal patient until Sunday, or for any other reason there is no PCI planned, then you it's maybe possible to upload them with the one platelet.
I agree.
But في شغلة دكتور عباب نسيت and he flew through it. I think we need to go back to it. Is how to assess the success of thrombolysis. Once you give a patient thrombolytics, how would you know that I'm done or I'm not done? I mean, the way we practice it is those patients, if you decide not to take them to the cath lab and study their anatomy, you really have to do a modified Bruce protocol stress test on these patients before you let them go home. Otherwise, like Dr. Belbisi said, he'll come back to you with a STEMI now. So that's how we release them.
But the guidelines are frankly here that each patient have to undergo a cath. You have to make angiography and the known anatomy and what's happened in these patients.
Because you mentioned sometimes that he's not PCI accessible or I don't know.
The question is successful thrombolytic therapy. I think we have the clinical decision primer to say it's successful or not, because regarding
chest pain, resolution
pain,
of the ECG
elevation
changes.
resolution and such things. These, I think the success rate, Dr. Mustafa can help with the numbers. I think we have success rate in primary thrombolytic successful rate in clinical settings is up to 80%. They are all good mainly. But when we make angiography in these patients, the real successful thrombolytic therapy is not exceeding 20 to 30%. That's just a few number where the angiography, where we don't need to put a stent, where you didn't find the lesion or a risk of thrombus.
Well, I mean, if you have more than 1% of the vessel open and you have TB3 flow, that's a successful thrombolytics, but that's not a successful.
في عندنا سؤال من
You know
الأودينس.
this
Just
when
one
you make
minute, because I
angiography.
want to make a very important comment on this one, which is the following. So this is an important point that you're bringing up, which is, okay, if I've given my patient thrombolytics, he's not out of the woods. As a matter of fact, it should be standard of care. If he gets a thrombolytic in the periphery,
cath in 3
to be
hours to
cath
24.
and transferred to a PCI-capable spot, not wait in the
Everybody
center.
has to get a cath after.
Yes, so he should actually be transferred. So he gets the thrombolytics, and then he's transferred immediately to a PCI capable. In a lot of cases, what happens here is that he stays in the place where he doesn't
few
have
days.
for a few days, exactly. So
تفضلي
that
دكتورة.
Up to 1 week.
نعطي المايك بليز للدكتورة ورا.
Good afternoon, everyone. I'm a third emergency medicine resident at Jordan University Hospital. My name is Miriam. And we often have this very important thing to point out, which is when a person comes that he is already on dual antiplatelet, and then he has taken it in the morning, and he comes with an ST or non-ST, regardless. Is there a time frame for how much should we emit from the loading dose? Is there a specific thing, or should we give it fully, despite that he has taken it earlier in the morning? If the patient was on dual antiplatelet, Plavix and aspirin, and now he's coming with a non-ST, let's assume, or an ST, should we omit part of the dose of the loading and give the rest, or we should give it fully, like 325 or 300 to 600 Plavix?
Or
let's assume.
let's answer also another part of the question. If he or she is on a clopidogrel and comes with an ST,
True.
would you continue clopidogrel
No.
in the ER or switch him immediately in the ER with loading of Brilinta?
That's also a question that I wanted to ask.
I think
Let's
without
say he
knowing-
took an aspirin 100 milligram at the morning, and now he's coming with an ST. Do you give 200 extra, or do you give the 325 fully?
I personally would reload them like brand new, because there comes the question of the compliance. Was he taking it once a week, every other day? We don't know. So you really have to assume
Reload,
that
yes.
he doesn't have enough of it in his system.
Reload.
Reload.
No, but that's the thing. That's what we're doing here.
I hate to say that. It's all in the guidelines again. People who are already on dual antiplatelets come in with an acute coronary syndrome, you load them. So you have to load them. So the other thing is clopidogrel switch to
Ticagrelor.
the answer in the guidelines again. You switch.
Reload.
We switch
You
and
switch
reload.
unless there is a good reason of not switching. I think
دكتور احنا عارفين كلهم الجايد لاينز بس في عندنا medical students ER residents
I know.
so these are all questions عشان ينكش المخات
100%, and that's the idea of this
احنا كلنا عارفين
conference.
الجايد
This
لاينز
is the idea of this conference, to actually to stay, because there's also a feeling that maybe the guidelines doesn't fit our community or doesn't fit our practice. No, there are parts which a lot of it actually fits us. We should do that. We should, stick with it.
طيب اظن خلص وقت الغداء للكل جوعان
يعطيكم العافية.
وشكرا يعطيكم العافيه